For people who don't know me, my name is Eddie Ritson. I'm a Programme Director within the Digital Health and Care Northern Ireland team. Welcome to this, I think, the 10th in a series of digital dispatches, which the DHCNI team have developed over the last number of months as a way of opening up discussion, I suppose, about the potential of digital within the broader health and social care system. Back in 2017, I think it was, I was asked to take on a role as Programme Director for a programme which was called the e-health and data analytics dementia research programme, I think, something like that. It was a very, very long and convoluted title. And the programme, which was jointly funded by our Department of Health, the Executive Office and Atlantic Philanthropies, had a number of different aspects to it, including, amongst others, the commissioning of a formal programme of research from Queen's University, Belfast, the establishment within the health and social care system of a data analytics capability, and also the development of real-life applications of data analytics to help to drive improvements in the care of services to people with dementia. And myself and a number of colleagues, some of whom are on this call today, wanted to find a way of bringing those three strands together. And we established what I think I would refer to as a community of practice called the Dementia Analytics Research User Group, or DARUG. For those of you who don't know, you've maybe heard of the phrase DARUG and didn't know what it stood for Dementia Research User Group. And the idea was to try to find a way of bringing life to research, that we didn't just do a piece of work that sat on a shelf somewhere, but we actually brought together frontline care professionals, academics, experts in data analytics, people from industry. It was a very inclusive community of practice, that we bring those people together, coming from different perspectives, to help to find ways of using data analytics to improve the care of services to people. And in the last of those three strands, the development of real-life applications, I think we funded something like 15 different programs of work. And I'm delighted today to introduce a couple of people who worked on at least two of those programs. Dr. Frances Duffy, consultant lead psychologist in the Psychology of Older People's Service in the Northern Trust. Hello, Frances. And Dr. Barry Devereux, lecturer in computer science at Queen's University, Belfast. So I'm going to just hand over, Frances, Barry, I'm not quite sure which of you are going to go first, maybe yourself, Frances. I'll hand over to you at this stage. I see a lot of people have got their camera switched off, which is fine if you're munching away on a sandwich and having a cup of soup or something. But if you want to put your camera on, you're very welcome to do so, as sometimes it can be difficult speaking to a black box. Please do make a note of any questions you want to raise. Feel free to fire them in at the end. And if you want to use the chat facility, that's okay as well. We'll keep an eye on that, and we'll come back to some Q&A at the end of the presentations. So with that in mind, I'll maybe turn over to you, Frances.
Thanks, Eddie, and thanks very much for inviting me to talk today. Let me just start my slideshow. Okay, so I'm going to talk today about using dementia assessment data and machine learning to support timely differential diagnosis of dementia. And I haven't done this work on my own. As Eddie mentioned, it was very much a collaborative approach. So we have a team within the Northern Trust, but we also have an excellent team within Ulster University who've supported us with some of the data analysis. And then we have a team in Nightingale Analytics that have supported us with the algorithm that I'll talk about and the dementia assessment app. So it's very much been a collaborative approach. And again, I just want to thank also, Eddie had mentioned DARUG. So this work's been supported by Health and Social Care Board Executive Office, Department of Health and Atlantic Philanthropies. So we wouldn't have been able to do this without that support. So the aims of our project, so we had two projects running in parallel, where the first was to understand the profiles of the different outcomes following an assessment for dementia in the Northern Trust. We also wanted to create a dementia assessment app to collect data, assessment data ongoing. And then we also wanted to explore the use of AI to support timely diagnosis. So I'll talk a little bit about all three of those things this afternoon. So first of all, why is timely diagnosis important? Well, the first thing is that it supports better adjustment. So if the person understands why they might be having the experiences they're experiencing because of a dementia, then it helps them to adjust to that diagnosis. Also, if we can provide them with supports and potentially some medications, we can actually slow the progression of the dementia. We enable people to plan ahead and make decisions because, as we know, dementia is a progressive condition. So as it progresses, the person loses the ability to plan and make decisions. So we can enable them to do that, make decisions about their future in a timely way. And also there's significant cost to the health and social care system with timely diagnosis. So that's why we actually want to address this issue. So I'll tell you a little bit about the data we collected. We looked at all of the referrals to our memory service between 2013 and 2019, and the total number of assessments was 2,962, so almost 3,000 people attended the service at this stage. What we find, that you've got some unique assessments, that's people who attended just once, but there are also individuals who return for a second visit if their diagnosis isn't clear or there's been some kind of change over time. And these people are actually really important. So depending on time of this talk, I'd be happy to talk a bit more about the people who actually return for a second assessment, because that enables us to track progression from mild cognitive impairment, for example, to dementia. And we collected 75 features or data points from all of these people. So just to give you a flavor of what the features were. So we had general features, which were, age, gender, education level, occupation, etc., hearing, outside problems, whether they had a package of care, whether they were independent with things like medication. We also then collected information about different symptoms that the person's reporting. So did they have insight into the fact they had difficulties? What about the onset of symptoms? What about the progression of symptoms? Were they experiencing hallucinations, delusions, etc.? We completed various psychometric assessments. So we used the Addenbrookes cognitive exam, which is a fairly brief screen of cognitive function, which is used commonly for a variety of different impairments in cognitive function. We looked at the activities, the Bristol Activities of Daily Living scale and the Zarat burden interview. And then we also recorded physical health risk factors for dementia, such as history of epilepsy, head injury, stroke, diabetes, etc. So all of this data was collected from all of the attendees to the memory service. So if we look first of all at gender and age, 62% of the referrals are female and 38% are males. If we look at the spread of age, the average age was about 80 years old, but we had people who were a small number of people in their 40s, and we had people who were over 100. So the potential outcome of an assessment of the memory service. So we get a referral, you complete the memory, the memory assessment service process, then you either get a diagnosis or you get no diagnosis. And these are all of the range of options. So there's a variety of different dementias that someone could be diagnosed with. They could get a diagnosis of mild cognitive impairment, which isn't in fact a diagnosis, but they could be told that they've got a mild cognitive impairment, or there could be an uncertain diagnosis. And we also collected some data from a control group. And these were people who didn't present to the memory service. They have no history of a diagnosis of dementia, and they were recruited via social media and word of mouth, because it's really important to have some control data to compare against the other conditions. So the outcome of the memory assessment then, what we find is that 22.4% of our referrals get a diagnosis of dementia. And then with some of the less common dementias, you can see there's a lesser percentage that present. For example, only 0.3% of referrals have a frontotemporal dementia. What's really interesting about this data is that 27.5% have a mild cognitive impairment. And what's really interesting for us is that with people who have a mild cognitive impairment, some of them will remain stable and they won't change. Some of them might actually even get better, but some of them will go on to develop a dementia. So we want to, in the future, interrogate about whether or not we can predict who will go on to develop a dementia from a mild cognitive impairment. And then we had 11% of people who don't have a diagnosis of dementia. And this is another important population, because these are people who potentially should be referred to other services, or they may actually be people who are quite well. So we need to understand a bit more about what this population looks like. And I'll explain a bit more about that at the end. So for the people who didn't have a diagnosis, what we found is the majority of them actually had a mental health difficulty. So these are the people that we really need to target and understand a bit more, because rather than referring them to specialist memory services or dementia assessment services, they'd be best referred to psychological therapy service potentially, or for other services. So we need to find out, can we give the referral agents better information about this population that will actually reduce the unnecessary referrals, because being assessed for dementia is very stressful, anxiety provoking experiences, and we want to avoid that if possible. And then some of the other people who didn't get a diagnosis had either a brain injury or just an age-related problem, or some of them had Parkinson's disease. So why is this data important? As I've already mentioned, 45% of referrals don't have dementia. So can we provide better information to the referral agents to tell them what type of people should you refer for specialist assessment? And then the other 27.5 who have a mild cognitive impairment, can we predict whom of these will develop a dementia? So if we're going to look at how we interrogated the data, and there's a lot of data here, and I'm going to show just a little bit of it, but I wanted to show you some box plots to show you the complexity of the data that our clinicians are faced with when they're trying to make a differential diagnosis. So the Addenbrooke's cognitive exam is a screen that we use. And if we look, I'm just going to look here at 3 of the dementias. So if you look at Alzheimer's disease, vascular dementia, and mixed dementia, you can see that the Addenbrooke's isn't very good at differentiating between what type of dementia that somebody has. But it's obvious then, you can see that mild cognitive impairment do better than the dementias, and the control subjects do better than the mild cognitive impairment. So the cutoff for clinical screening is 88. So you can see that our control subjects were well within that range. And then the mild cognitive impairment and the dementias were less than that. Now, the Addenbrooke's has got 5 different domains, and we can look then at each of the domains of the Addenbrooke's, and we can say, is there anything in these domains that could help us to differentiate between the different types of dementia? Because when we're making a diagnosis, it's important not only to know that the person's got dementia, but what type of dementia that they have. And you can see that there's some variability within attention here. So the mixed dementia looks slightly different than the Alzheimer's and the vascular dementia. And if we race through the domains of all of the domains of the Addenbrooke's, you can see that there's a varying picture of differences between dementias, mild cognitive impairment, and controls. But for some of the domains, it's difficult to differentiate between the different dementias. You can see that with fluency here, Alzheimer's disease seems to do slightly better in fluency compared to the other 2 dementias. Again, they're all different from mild cognitive impairment and controls. And these are decisions that clinicians are trying to make. They're trying to take all of this data together and make sense of what diagnosis someone has. If we look at the language domain here again, you can see that there's a little bit of difference here potentially between the vascular dementias and the other 2 dementias, but they're not big differences. And the visuospatial, we can see that there seems to be some differences coming out with Alzheimer's disease compared to the other 2 dementias. And what we did was we did pairwise comparisons of all of these all of the domains of the Addenbrooke's. And we can see actually that the total score on the Addenbrooke's can't differentiate between the dementias. But what it can do is we can see that the mild cognitive impairment do significantly better than all of the dementias, and the controls do significantly better than everybody else. So it tells us that looking at total scores can tell us potentially whether someone's got a mild cognitive impairment or whether the control subject, but they won't be able to tell us what type of dementia that they have. But what we can see is when we start to really dive into this data, we can look at some comparisons here, and we can say, well, if we look at the domain of attention, attention's different compared from Alzheimer's disease compared to a mixed dementia. So can we look at attention scores to help us to make a difference between a differential diagnosis between these 2 dementias? And then if we look at one of the others, we can see memory. well, actually memory significantly different also for the Alzheimer's disease and the mixed dementia, but it's not between vascular and Alzheimer's or vascular and mixed dementia. We can look at the fluency, and again, we can see that there's significant differences here between the, I can't even see my own finger, hold on a second, between the mixed dementias and the other two, but the Alzheimer's and vascular, there's no significant differences. The same with, whenever we look at language though, we can see that language is significantly different between vascular dementia and Alzheimer's disease, but not the other two dementias. So again, we're trying to use all of these bits of information. And when clinicians are making decisions, that's what they're doing. They're weighting all of these nuances between the different profile across the patients and trying to make a decision about whether or not the person A has dementia and whether it's a vascular dementia, is it mixed dementia, or is it something else. Other things that we can look at is whether the person has insight into their difficulties. So if we look at Alzheimer's, vascular and mixed dementia compared to mild cognitive impairment, we can see that mild cognitive impairment tend to have insight into their difficulties. So what that means is that they're reporting that I've got difficulties with their memory, whereas the people who actually have a dementia are less likely to report that they've got difficulties with their dementia. They've got less insight to the fact that they're having difficulties. If we look at the impairment activities of daily living, what you can see is that the dementias tend to have more impairment and activities of daily living, whereas the people with a mild cognitive impairment tend not to have impairment activities of daily living. And this is all of the information that helps us make this differential diagnosis. Is the person a good historian? You can see then that people with mild cognitive impairment can tell you about their life histories, whereas the people with dementia are less likely to be able to tell you about their history. So that's another piece of evidence that we can use to suggest whether somebody might have a dementia. We can look at whether or not people report cognitive difficulties and the self-reported difficulties. So what's interesting here is that the people with mild cognitive impairment are actually more likely to report that they've got difficulties than the people with dementias, which is similar to the idea of insight. But whereas if we look at the carer-reported difficulties, there isn't really any difference. Carers are as likely to report difficulties with people with mild cognitive impairment as they are when the person's got dementia. So we completed a series of analysis here, and we published the first paper in the European Journal of Aging. And we're continuing to collaborate with the University of Ulster, and we have a PhD student that's actually continuing to do the data analysis in this work. So we're trying to tease out then about the different patterns and profiles. It's an ongoing piece of work, and there's probably at least a couple of PhDs in terms of research, which we will continue to work on. And we had a research meeting yesterday, so we've already got plans for our next paper to publish some of this data. But what we're also interested in then, though, was a second strain of this was to look at, I hope I've highlighted the complexity of the decisions that the clinicians are making. They're taking, 72 features of information and trying to make a differential diagnosis. So can we use this data to help the clinicians make these complex decisions about diagnosis? So this is where we applied machine learning techniques to the data to build a predictive model to help them to support clinicians to make that diagnosis. So the model that we currently have is using, and again, the algorithms we're continuing to work on these. The current algorithm that we're reporting here uses 30 of those 72 features. So the algorithm pulled out what are the 30 best features that predict a difference between these different client groups. And so we've got the cognitive impairment versus non-cognitive impairment. So that could be a mild cognitive impairment and a dementia compared to no cognitive impairment. And the sensitivity is that the ability to predict whether somebody has cognitive impairment is 82, and the specificity, which is the ability to reject the negative cases, as in the person doesn't have dementia, and I hope I've said that the right way around, because sometimes I say it the wrong way around, is 85. And the accuracy is 82%. So this model is doing pretty good. But then when we look at the ability of the model to predict dementia versus non-dementia, so that would be the mild cognitive impairment versus the dementia, it's still doing good, but it's not doing quite as well. So the sensitivity is 76 and the specificity 72, the overall accuracy being 81%. So what we have here is we have an algorithm that has been trained on the data, and then it uses the non-test data then to predict what the outcome of the assessment is. And as we collect more data, then we can increase the sensitivity and specificity of this model. So at the same time as we were collecting all of that data, is that we developed a dementia assessment app, and we digitized our assessment process. So the app then enables data capture, validation, and storage. And I'm just going to very, very briefly do a brief demonstration of the app. So I'm just going to share my other screen here. So in this app, what we have is we've got a variety of different kind of menus as you run through your assessment. So I'm just going to check cognitive difficulty. So what we can do is we can ask, in terms of our clinical interview for the patient, are they repetitive in conversation? And then the clinician can answer yes, no, sometimes or unknown, as in the person wasn't able to respond. We can ask the same questions of the carers. So we can ask a variety of different questions that are important as part of our assessment, and then we digitally capture these. So if we look at the case overview, you can see that this app enables you to move backwards and forwards between the whole assessment process. So what it means then is that we can actually digitally capture our memory service assessment. And it means then we've got ongoing data collection into the future. So we're piloting the app in the Northern Trust just at the moment. So what are the benefits of the app? So it really, there's 100 benefits, but it means that we can easily monitor changes in function. So someone presents to clinic and they may not have a diagnosis of dementia. They present to clinic at some point later. We can actually compare and easily track what their performance was across assessments. What we can also do is we can take parts of the app and we can monitor changes in specific functions. We can even look at carer stress, and we can look at how carer stress changes over time. We will hopefully be able to predict the mild cognitive impairment at risk of developing dementia. And because we've digitized this data, we can then use it for ongoing research to better understand dementia. And those are just 4 of the many benefits of being able to collect data in the app. So the next steps for us really are, we're piloting the app in the Northern Trust. We're trying to secure data to collect additional control data, because we were only able to collect control data from 30 participants. But really, to make this extremely beneficial in terms of real clinical practice, we'd need to have a much larger control group. So that's our next steps, and we're exploring funding for that. We will continue to refine the algorithm as we collect more data ongoing, and then we will apply for MRHA approval to use the algorithm as a clinical diagnostic tool. That's the end of the presentation, but I cannot leave without just letting you know about our Clear Dementia Care app that we've also developed with funding support from Health and Social Care Board. So please feel free to download the Clear Dementia Care app from the App Store and Google Play. And that is the end of my presentation. Again, thanks to our sponsors. And I'll be happy to take questions now or at the end, whenever you think, Eddie.
That's great, Frances. Thank you so much. And I hadn't expected you to plug your Clear app, but I'm not surprised that you did. And that's another feather in your cap. I wonder if we might just actually move on to Barry's presentation. If you're able to stay with us, Frances, for the rest of the hour, we'll move on to Barry's presentation, and then we'll come back to any questions at the end. Barry, over to you.
Okay, so thank you very much for giving me the opportunity to talk. So so I'm a computer science lecturer in Queen's, and my area of research is in artificial intelligence and natural language processing. I do have a previous life as a postdoc in a cognitive neuroscience of language lab. So there's kind of an interplay between my research in natural language processing and looking at language and cognitive impairments as well, even though that's not necessarily part of the research that we've been doing here as part of the DARUG project. This project was about analyzing and understanding unstructured narrative text that we can find in clinical letters, and representing the information in the clinical letters in such a way that, first of all, adequately captured the meaning of the sentences and words in the clinical text in such a way that we could then use that representation of the text in downstream tasks, for example, as part of a clinical decision support system, or as a tool for helping researchers to select patients for clinical studies, for example. Okay, so we focus on electronic health records, and as we all know, these are a very useful tool for tracking patient well-being over time. analyzing the effects of different treatments over time, or selecting patients for clinical trials, and so on and so forth. And there are two kinds of electronic health data. So we can talk about structured data. So by structured data, I just mean numeric data stored in a database, like the age and weight and blood pressure and responses on various neuropsychological tests and blood test results and so on and so forth. So structured data meaning anything that can be stored as a number in a spreadsheet or in a data set. And of course, these kinds of data are quite easy to access and process. So we can do statistics on this kind of data quite easily. For example, we just have to look up the values that we're interested in the data set. So the focus of this project was more on the unstructured data that we have in electronic clinical health records. So for example, text written by the clinical consultant in letters about the patient. So here's an example of a fictional piece of text from a clinical letter. So she presents with a 3-year history of poor short-term memory. Onset and progression are described as insidious. Her son has noticed she has become poorer with orientating herself over time. She suffered a serious concussion 12 years ago, so on and so forth. So some results on neuropsychological tests and so on. So we may have like 1 to 2 to 3 pages of text in a letter describing how the patient has presented at the clinic. And obviously there's lots of important information here about the patient's condition, even though it's not stored in a database. So anyone reading the letter could understand quite well the situation of the patient. But the point is that someone has to read the letter and understand it in order for the letter to be useful. A clinician has to read it, or someone working in the clinic has to read it in order for it to help to be useful to the patient. So in this project, we focused on how we can analyze the text in these kinds of letters automatically. So we turned to artificial intelligence to do this. And there's been a lot of recent progress in artificial intelligence, specifically in the area of natural language processing over the last, 3 years, I suppose. So there was kind of a big development in NLP in 2018, 2019 that gave us methods and types of models that can be used to process textual information, unstructured textual information, very effectively. So the purpose of our project was to leverage these models in order to represent the meaning of text in a way that was going to be useful, in the sense that it would usefully encode important diagnostically relevant information from the letter about the patient. Okay, so we wanted to have a system that could extract information from the free-form narrative text, and in particular be relevant to different applications in dementia care and diagnosis. So for example, having good representations of the information in the text could be useful for supporting clinical decision support. So automatically helping clinical practitioners to track things like disease progression, how treatment is working for patients, and so on and so forth. And other tasks that we considered over the course of this project were things like identifying patients with particular patient histories for clinical trials. So obviously a lot of the information that might be relevant to who you may select for a clinical trial will be found in the letter itself. And again, when researchers are selecting patients for clinical trials, they would typically go to the letters and understand the details of the patient and decide whether they're relevant for their trial or not. So we can see how being able to automatically process and understand this text can be useful with that workload. Okay, so the project was divided into sprints. So I'm going to broadly talk about it in terms of the sprints. So the first part was data collection and pre-processing. So we had to collect a large set of letters from memory clinics in Northern Ireland. And in particular, the letters we worked with were letters associated with patients of Alzheimer's disease, Lewy body dementia, mild cognitive impairment, and also healthy, non-impaired individuals. So we were working with about 800 letters in total. That the number of letters we're working with has grown over time, and additional letters can be incorporated quickly and easily into the natural language processing system that we developed. And it's probably worth mentioning at this stage as well, is there's nothing particularly specific about letters from memory clinics that makes the system that's relevant to this system. So the systems that we've developed can work with any unstructured text, not just necessarily clinical letters about memory clinic patients. Okay, so how do we go about representing the information in this unstructured text? Well, the key idea is to do something kind of like what we've done with what people do with the structured information. So the structured information is just numbers in a database. So we need to convert the information that's in the unstructured text into a set of numbers, essentially. Okay. And how do we want to construct it? How do we want to convert it into a set of numbers? Well, we want to do it in such a way that we capture something about the meaning of what we see in the text. So you can think of it this as a bit like making a map. So when you make a map, you have like a continuous space, and every point in that space has a coordinate. So how far north or south you are, or how far east or west you are. And we can talk about two things being similar or close together in the map, or far apart in the map. So that's the kind of framework we're using to represent meaning here. The distance between sentences or words reflects how similar they are in meaning. So here's kind of a brief illustration of that. So feeling well and healthy are obviously two phrases that kind of mean the same thing: high blood pressure and hypertension, medicine and medication, and so on. So it's not about surface level information in the letters. It's not about keywords or particular phrases that appear, but it's about representing the meaning of those phrases, the meaning of those words, and how we represent the meaning of the phrases or the meaning of the words is captured in some sense of the distance between them with respect to some kind of coordinate system. So you can also think of it a bit like a library. So if you go to a library and you take a book from a shelf, well, it's very likely that a book close by is going to be similar on a similar topic. So the library is organized in terms of distances by similarity of meaning, or the similarity of what the books are about. And this is exactly the same kind of approach of this kind of modeling. So we used a bunch of very recent large-scale pre-trained language models. So BioBERT, Clinical BERT, Discharge Summary BERT, and so on. For some reason, there's a trend to name things after Sesame Street characters in natural language processing. So that's where BERT comes in. But these are very large models that have been trained on very general data, but they can then be adapted or fine-tuned to particular data sets and particular tasks. So that's the kind of approach that we've used here. So we have text from our clinical letters. So for example, she has a past medical history of hypertension and hypercholesterolemia, whatever that word is. And we basically feed the text through our model and basically, as I said, convert it to numbers, where the numbers represent the kind of spatial relationship between the sentences in our text. So in this sprint, the second sprint, we were interested in whether we could build a model that represented the meanings of sentences and evaluate the model in terms of human data. There is human data sets that have been created using clinicians, so experts, where different sentences have been rated for their overall similarity. So for example, if we have a sentence like, he has very high blood pressure, and another sentence that says, this man has hypertension. Well, obviously those two sentences are very similar in meaning, even though the words don't overlap in the two sentences. So the model needs to be able to capture that similarity of meaning. So we built our model and we evaluated it on a large set of sentences that humans had given a similarity rating to. So the point here was how close or how similar were our predictions of the similarity between pairs of sentences compared to the human ratings of similarity. And the correlation we got with such a model was 0.87. So this work has been written up for a paper in a bio-NLP workshop at ACL in 2019. Lots of people use the same sentences and try their models on the same task. IBM got the best results in the workshop, but we were the best team outside of North America. So we were quite pleased about that. So the point is that every sentence in our clinical letters can be represented as a point in one of these spaces. So one of the points here, for example, might represent the sentence, "She has 4 children and several grandchildren." And other points nearby, like in this red circle, will also represent sentences about family relationships and so on. And in other parts of the space, over here, for example, we might have information about the kind of medication that the patients are on, for example. So it's an arrangement of the sentences from our clinical letters in a way that makes sense meaningfully. Okay, so in the third part of the project, we focused on predicting the patient diagnosis. So predicting the patient diagnosis in and of itself is not a particularly useful task because we already know what the diagnosis for these patients are. But as a way of training and developing the model, a model that can accurately predict what the diagnosis is from the information in the letter is necessarily a good model. So if we train the model to predict the patient diagnosis, the model will represent the information in the letters in a way that makes sense with respect to the diagnosis. So we can look at the model in terms of what information is important to the model and what information is not important. So obviously in these letters, some information is going to be highly relevant to the diagnosis. And other information, like let's say the patient's address or something like that, will be completely irrelevant to the diagnosis. So by building a model that predicts diagnosis, it gives us a way of looking at what information in the letter is particularly clinically relevant. So the outcome here was to build a model or representations that have been fine-tuned to the task of predicting patient diagnosis and then examining what the model tells us about the clinical relevance of the text. So as I mentioned, we have this kind of spatial organization of the sentences that make up our clinical letters. And the color coding of these points reflects how relevant each sentence is to different categories of diagnosis. So on the left-hand side here, higher, warmer colors, more orangey colors, represent sentences that are particularly relevant to the diagnosis of dementia. And as you can see for the class of mild cognitive impairment and non-impaired, the coloring is different. So some sentences may be quite relevant to dementia diagnosis, and other sentences may be relevant to mild cognitive impairment or being non-impaired. We can also cluster the points, cluster the sentences making up this space, and look how different clusters are relevant to particular diagnoses. So in the line that I've highlighted here in red, the top bigrams in the cluster just reflect the phrases that tend to occur in sentences in that part of the space. So for example, that we have sentences that cluster together that often mention children. And we can see here that for the cluster of sentences that often mention children, there's a high correlation with a non-impaired diagnosis. So the correlation is quite high between the score that the model gives to sentences that contain these words and a non-impaired diagnosis. For another cluster, so for a different part of the semantic space, the cluster 9 here, for example, so we have ischemic heart, heart disease, medical history, and so on. And we can see that for sentences which tend to cluster in that part of the space, those sentences tend to be particularly relevant to a mild cognitive impairment diagnosis and so on. So different kinds of information in the letters can be associated with different types of diagnosis. And that tells us that the letter is, or the model is capturing information in the letters that are relevant to the clinical condition. So finally, we want to put the model that we had developed and evaluated and investigated together with something that would be useful for clinicians. So the next part of the project was understanding building a clinical supports tool or something that would be useful for researchers that would apply the model that we had developed. So there are many different things to consider in terms of how the model can be applied to actual real real use cases. And we can think about these from the perspective of different people involved in clinical research. So as a clinician, being able to review symptoms or check the recommended treatment course, or retrieve previously reported scores on various neuropsychological tests and so on. So this information can be retrieved automatically from the letters and may be relevant to supporting the clinician's work and the decisions that the clinicians are making. Similarly, a medical administrative assistant could use a system that extracted information from the unstructured text to do things like check the time that has elapsed between the current appointment and previous appointments and so on, and relate that to information about how the patient is presenting and so on and so forth. And researchers often use clinical letters to investigate what symptoms are associated with particular conditions or particular patients, and in particular in the context of selecting patients for clinical research trials. So a clinical researcher looking for patients for clinical trials may retrieve a list of patients from particular clinics and go through the letters for those patients to select the patients that meet their inclusion criteria. So obviously this is a very cumbersome and time-consuming process because it's perhaps the case that the information that's relevant to whether or not a participant should be selected for a clinical trial is information that's only found in the letter. So let's say you're doing a clinical trial where you want people who are mildly depressed, not socially isolated, but who had a concussion more than 5 years ago, something like that. That's the kind of information that you would expect to find in a clinical letter. But obviously it would be very cumbersome to go through letters and find that information. If a natural language processing system that can represent the meaning and the importance of the information in letters can be very useful for automating that kind of process. So that's the kind of process that we have kind of focused on, or the kind of use case that we've focused on in this part of the project. As I said, one thing that we need to be able to extract from the letters for selecting patient cohorts for clinical trials is inclusion criteria and exclusion criteria. So what do we want to be true for the patients and what do we want to exclude from the patients? We worked on automatically identifying patients with particular properties as a kind of an important downstream task for our representations. So how can we do that? Well, I think I've kind of talked about that already. What we did was we built, or what we proposed was a system where there would be kind of a gold standard letter. So a letter for a perfect patient for a clinical trial. And again, in the sense of representing letters in terms of their similarity, we can then extract patients from a very large data set that are similar or are close to our kind of prototypical patient, the patient that perfectly matches the features that we're interested in, the inclusion criteria and the exclusion criteria. So this notion of similarity or distance in the semantic space can be used to basically rank potential candidates for a clinical trial by how similar they are to the most ideal patient, if you like. So that's just an example of how these kinds of systems that can process unstructured text and represent it in a way that captures the meaning of that text can be used to aid researchers and clinicians in real applications. So that's my presentation. So again, I'm happy to take any questions. And yeah, and also this work was carried out with Mark Ormerod, who was a PhD student of mine. So he took 11 months out of his PhD to work on this project. And yeah, he did most of the technical work. So that's my talk. So thanks very much. And I'm happy to answer any questions.
Brilliant. Thanks, Barry. We've had two very different presentations, which I think to some degree reflects the sort of variety of projects that we initiated under the Devereux concept. So I'm just going to open up for questions, and I don't think we'll take them in any particular order. So if people just want to put their hand up or put a message in chat, we will take them for Frances and Barry. I wonder maybe, Frances, though, just to get things going a little bit, if I could just turn a question to you to start with in relation to the Dementia Assessment app. And I see there's been some interest around the pilot in the chat box there. What kind of impact do you think that assessment app potentially could have on referral pathways for people with or suspected dementia?
Phenomenal, Eddie. I suppose whenever we developed this, we developed it thinking about the regional dementia care pathway and the potential move towards some more assessment within primary care. And the way that we set up the app is that some of the questions could actually be answered within primary care, and some of them could actually be answered by the carers even at home. So we'd be able to unlock bits of the app so that different people can complete different bits. So I think the first thing about it is it will reduce duplication, because if the GP completes part of it within primary care, then that won't need to be completed again within secondary care. The other thing that I think that could potentially happen is if we had, for example, memory practitioners within primary care, they could actually be completing the assessment with the service user or the patient, and then there could be a decision made in collaboration with the GP and potentially secondary care about whether that person needs to go to secondary care, because you can see the fact that 40% of people don't have a dementia. So we should potentially be able to reduce some of that 40% of people actually going to secondary care. And then also what you find in the app is there are very obvious dementias. There are people who clearly their profile is a dementia, and they could actually remain potentially within primary care and be diagnosed within primary care. And then you would leave secondary care for those more complex ones where potentially you weren't sure about what the diagnosis was and you wanted another opinion within secondary care. So the potential for this is, I mean, when you look at it, it's phenomenal. We also include the caregiver burden. And within GP practice, they could almost 6 monthly just screen caregiver burden. And what you could see then is actually this caregiver is experiencing increased stress. We need to put some supports in. So before we develop crisis. So there's lots of, I mean, every time we kind of talk about it and think about it, there's more potential options for it.
Great, thank you. Barry, I see there's a question for you in the chat box from Shiva.
Yeah, so the question is, can the text be analyzed from all text documents, e.g. PDFs, docs, text files, and so on? So the data we were actually working with here was actually visual scans of redacted clinical letters. So there was a physical process of redaction and then rescanning. So they were image files, but we used optical character recognition software to process the text in those images. So there are tools for doing that, yeah.
And as a follow-up to that, Barry, like you know, your presentation there was very comprehensive, and it's obviously quite a complex area. What stage do you think we're at in terms of the overall application of natural language processing for clinicians and researchers? You know, is it the sort of thing that you think people are going to begin to utilize in the next X months, years? How's it looking?
Well, in terms of the technology, it's getting better all the time. And as I said, it has been the research has been progressing faster in the last 3 years in this area than in any previous period of time. And in lots of different applications that people train and test such models on, they can often work and classify text, for example, or summarize texts, or make judgments about the category that a text belongs to, or what the emotion or the sentiment in the text is, and so on and so forth. They can often make these predictions, the models, as well as humans can make them. So in terms of the technology is definitely mature enough now for real use. I guess the more interesting question, and the question maybe that's more relevant to this audience, is what's the actual application going to be. So I talked about applications in terms of selecting patients for clinical trials, but that's obviously just one application that we focused on in this project. I'm sure there are others, but I've never worked as a clinician, so I'm probably not the best person to decide what the application should be. So these kinds of forums are probably interesting from the point of view of seeing how the technology can go together with actual real-world use.
So I know some of the people on the call, but I'm reluctant to call people out individually. But Frances, I wonder just for you on that issue about the actual application, what would your perspective be from a professional point of view?
Of the MPL?
Yeah.
I suppose I'm not sure. Like in terms of kind of clinic letters, in terms of diagnosis, I think if the diagnosis, if the information is there in the letter, then the diagnosis has probably already been made. So I suppose in terms of thinking of research trials, in terms of selecting candidates for research trials, I suppose that might be, really helpful use of it. But I'm not sure in relation to kind of diagnosis or for me in terms of like clinical monitoring. I suppose I'm not sure, but it's probably because I just don't know enough about it.
It might be one of those things that it's going to take a while to penetrate into sort of professional thinking about how that sort of new approach can be utilized in real life. Sometimes these things, like a lot of innovations, have quite a long incubation, but it's maybe something worth talking about in professional circles. Linda, you've got your hand up.
I have indeed. I'm just curious about the application. And Frances, just picking up on what you had said about the diagnosis has already been made. What about disputed diagnosis? Maybe families not being too accepting of a diagnosis, etc. Could there be any potential use in those circumstances?
I'm not sure really, because the prediction of diagnosis that we make from the letter is based on what the clinical judgment is from the clinical consultant. So if they're firm enough in their in what they write in the letter, then the model will just basically give you that prediction back. I should mention that even though we were predicting diagnosis as one of the tasks that we were using to fine-tune our model, that was from the perspective of not that being a kind of a clinically useful thing to do, because as I mentioned, we already know what the diagnosis is for these patients, but more so it was done in order to fine-tune the model in such a way that it has to capture the clinically relevant information in the letter. So it can't predict what the diagnosis is unless it can capture the clinically relevant information in a meaningful way. So it was predicting the diagnosis itself wasn't kind of the goal, but that was the thing that the model was trained on in order to get good representations, if that makes sense.
Yeah.
Thank you.
Thanks, Barry. So just it's 5 to 2, and we're going to be closing this call at 2 o'clock. So just as a bit of saying that to you as a catalyst for you to think of questions you may wish to pose at this moment in time. So you've got a question for Barry.
Yeah, I have seen, thanks Eddie, I've seen examples of NLP used for social care, kind of because a lot of social care data is obviously very unstructured data, and I'm wondering whether, have you seen any models being developed that are using social care? I suppose you had all your digital, your models that were based on clinical data, but is there any that been developed for social care data?
In terms of applications, I'm not familiar with any. That's probably something that I should look into. I know there's a lot of work in terms of looking at things like perhaps even more unstructured than what you're talking about. Things like tweet information. So how information and what people might tweet or post on social media, how that might relate to the things like depression and the progression of depression over time. So I know there's research in relating patient-generated text to clinical information, which seems quite interesting to me.
Thanks, Barry. Okay, as I mentioned, we're going to close at 2, but before we do that, I meant to give a bit of a shout out earlier, and I skipped over it to my colleague Sue Hunn here. Sue has been a driver behind the whole DARUG initiative and is leading in our team on digital innovation. And one of the things Sue's very keen to do is to find means and methods of improving collaboration right across our system on innovation and innovations. And I wonder, Sue, if you just wanted to say a thing or two about that.
Yeah, thanks, Eddie, for the introduction. I'm going to be very brief because I'm going to talk a little bit about how we've kind of from the original DARUG. It's still sustaining, we're still meeting on a monthly basis. So anyone who's interested can just let me know if you're interested to join. But it's really a very the success, I think, of DARUG has been always because it's very multidisciplinary. It basically combines clinical clinicians, commissioners, charities, healthcare informatics with industry and academia. So actually what you didn't see is in each of the time when the sprint was presented, you get all the different perspective that you don't normally get whenever you present your projects, because you get the whole plethora of people from people living with dementia saying, I don't really understand that, to actually that's really useful for me, to a GP who's saying, looking at Frances' tools, well, that actually means really a lot to me, because that's that may be the way future will have to work. So it's just to say that the success of it was very much multidisciplinary, and we're still continuing to meet because people want to continue to network. But also, lastly, I want to just share with you a place where, if you want all the details about the project, we've created a repository of the DARUG information onto a future NHS platform. And I'm just going to very quickly share my screen to let you see that platform. If you're interested to go in and have a look at it, let me know. So just going to share my screen. And this is the Health and Social Care Northern Ireland workspace that's on the Future NHS site. This is a fully funded site by NHS Improvement, and we now have a space there. And you can see there's different things there, but more importantly, I want to show you the DARUG workspace, which obviously has all, because it's a collab, I want to create this as a collaboration tool so that people can come together, look at some of the information. So all the information is there, all the upcoming events are there, any of the recent items, and then all the information about the individual projects are all there, any of the dissemination discussion forum, events, PPI work that we've done on PPI, the model for DARUG, why it worked and why it didn't work, the outputs and findings, all of them are all on the one platform. And then just like yourselves, any future webinars or current and future webinars will pass as well. Slides and all will be available on the site as well. So this site, we've got quite a few more people from DARUG who have already joined. And if you're interested to join, just drop me a note, and I'm the workspace manager, and I'll bring you in the site.
Brilliant, Sue. Thank you very much. This is like an advertising billboard, this thing today. So people can email yourself about that and get some further information about how to join. We've just hit 2 o'clock, so we will close at that stage. I'd be most grateful if people would just join with me in thanking Frances and Barry for their time today, and congratulations on both of your projects. Thank you so much.